Good evening, everybody. Thank you for attending the library's talk with the Connecticut Partnership for Long-Term Care Public Forum. Tonight, joining us is Aldo Pantano. And as you know, all our programs are made possible by your generous donations to the Darien Library Friend Foundation. And Aldo comes from the state's Office of Policy and Management Agency, and he represents the Connecticut Partnership for Long-Term Care. He speaks frequently on the topic of long-term care insurance and related topics. So without further ado, I present Aldo.
Well, thank you, Susie. Good evening, everyone, and thanks for joining us tonight. And a special thanks goes to Susie Scarrett, Amanda DeMayo, and Pat Sheary for making tonight's event possible, and really appreciate all the help they've been providing. I represent the Connecticut Partnership for Long-Term Care, again, working for the state of Connecticut. Under normal circumstances, we get about 1,000 people coming to different libraries and other places. But obviously, we're going through special times, so we're very fortunate that we can speak to you through this Zoom presentation. Unfortunately, we have a problem in Connecticut and in the rest of the country when it comes to paying for long-term care. And part of the reason is because there are many misconceptions and misunderstandings, and I hope to clarify a lot of confusion tonight and show you some of the problems and talk about solutions. One of the first misunderstanding is around what long-term care is and what long-term care is not. Long-term care is not health care. If somebody falls down, breaks a bone, ends up in the hospital, you have doctors, nurses providing skilled care, fix what's broken, x-rays, MRIs, CAT scans, try to send us home as quickly as possible and resume our normal life. With long-term care, we are talking about situations where people need help with everyday activities such as eating, dressing, bathing, going to the bathroom, transferring. And somebody may need long-term care because they have a cognitive impairment such as Alzheimer's, so they may not need physical help, but they need guidance and supervision to avoid harm to themselves or others, or wandering at 3 o'clock in the morning, or leaving the stove on and create a possible fire. The majority of long-term care is provided at home. That's where we'd rather be. But then you also have other settings such as adult daycare, assisted living, nursing home. People tend to focus on nursing homes and they say, well, I'm never going there, so I don't need this. The reality is that, again, most people receive care at home, and it's unfortunate, whether it's a car accident, a sports injury, long-lasting disease or disability. You have MS that attacks people at a younger age, Parkinson's, even with Alzheimer's. A friend of mine's sister at age 49, she was an attorney. She was diagnosed with Alzheimer's, and 5 years later, she passed away in a nursing home. Very tragic situations. Another friend of mine right now, his wife is 55, and she's been diagnosed with Alzheimer's, so they're trying a lot of different things. And lastly, a friend of mine's mother, she ended up having Alzheimer's for 20 years. I mean, that was a large part of her life. And on the good side, she had 4 daughters, 2 sons, and her husband, that they all took turns taking care of her. Eventually, they had to also hire somebody else to come in the house until she passed away. But at least she lived with her husband and periodically seeing the sons and daughters. And for some reason, Alzheimer's seems to prefer women. Now, experts don't agree 100%, but the general thinking is that the longer we live, the greater the chance of needing some type of long-term care. And women live longer, so that might be part of the reason why more women have Alzheimer's. Now, another misunderstanding is the risk of needing long-term care. As much as many of us think that it's just for older people, reality is much different. Close to 40% of people need long-term care. They're under the age of 65. And as I mentioned before, disease, a disability, an accident. I know a few friends 6 months ago going down the hill with bikes. One tried to pass the other one. The next thing you know, two of them are in the emergency room with a helmet cracked in 4 places, 3 torn ligaments, and a separated shoulder for one, and wrist damage, surgeries for the other one. You know, they were talking about people who are 55, 60 years old. And if that individual did not have a helmet, who knows what would have happened with possible serious injuries lasting for a lifetime. All right, so if we live to age 65, close to 70% of us will need some level of long-term care. So we can choose to ignore it, but reality is, as we get older, different things come up. And are there ways for us to protect our assets so that we don't have to spend our income and assets to pay for long-term care, which in the Northeast especially is very expensive. When we talk about the cost of long-term care, Connecticut is the second most expensive state in the country for nursing home cost. The state that is the most expensive, so don't move there. We're looking at, if you would like to see Russia on a clear day from your nursing home window, you'll be seeing, you'll be living in Alaska, where the average cost is $950 or close to $300,000 a year. Now, not everybody in Alaska can pay that kind of money. The majority cannot. So you have government programs and other ways to pay for the care. But in Connecticut, fortunately, we're not at $950 a day. But what we have here is an average cost of care in a nursing home of $456 a day. That's close to $166,000 a year. So we conduct a survey every fall, and then we publish the findings. And we've been doing that since 1989. Excuse me. Even if you're paying $70,000, $80,000 a year, you don't have to pay $100,000, $166,000. Many of us are simply not prepared for this type of expense. And unfortunately, we may find out too late. The average person paying $80,000, $100,000 a year, it may not take long until he or she becomes impoverished and then have to look for other ways for assistance. Now, notice here that since 1988, the average increases in inflation for nursing homes is 4.8%. Good news is that over the last 8 years, the cost of care has increased much closer to under 2%. And the average over the last 5 years has gone up a little bit. It's 2.3%. The difference between last year and this year is 2.6%. Obviously, we don't know what tomorrow, 5, 10, 20 years from now will look like, but it's good to see that the cost of care is not increasing as rapidly for nursing homes. And incidentally, when I started out here with the Connecticut Partnership 13 years ago, we had about 274 nursing homes in Connecticut. Today, we have 211. And that's for a lot of different reasons. But one of those reasons is that there's a big recognition that if we can find more options to keep people at home, then the cost of care is normally less. And therefore, people who normally would have gone to a nursing facility, for example, through Medicaid, now have more options where care can be provided at home. If long-term care is so expensive, who's paying for it? You have the 22.4% here that eventually end up becoming poor. They're paying for it out of their pockets. You also have over 10 million people that have purchased long-term care policies throughout the country. And in Connecticut, we have both people who have purchased non-partnership policies, and also more than 60,000 Connecticut residents at the time when they purchased the policies that had purchased partnership for long-term care policies. And I'll talk all about that shortly. Notice that Medicaid is the biggest payer of long-term care expenses at 61%. In order to qualify for Medicaid as a single person, you have to spend down your assets to $1,600. And the fun, unfortunately, doesn't stop there. When you're on Medicaid, you're also allowed to keep $60 a month out of your income, or 60 plus 90 if you're a wartime veteran. So as a single person, to be poor and qualify for Medicaid nursing home, spend down your assets to $1,600, and your income is limited to $60 a month. Now, if you're married, the state doesn't want the community spouse to become poor because the other spouse needs long-term care and has applied to Medicaid. So the community spouse gets to protect living at home. He or she gets to protect the house and the car, regardless of value. And then there's a formula in place, up to 50% of their other assets, but no more than 130,380. So the married couple, one spouse applies for the nursing home through Medicaid. The community spouse living at home gets to protect house, car, up to 50% of their other assets, no more than 130,860. Then they have to spend down everything else to $1,600. We can talk a little bit more about this if there are questions. Notice that Medicare is not even listed here. And that's because that's a misconception. You think somebody will pay for it, Medicare will pay for it. Medicare was not designed to pay for long-term care. As a result, Medicare turns away many people who apply for long-term care services. In order to qualify for Medicare, which on average pays about 24 days in a nursing home, or no more than 100 days, when the average length of stays is 2.3 years, both in Connecticut and the rest of the country. Obviously, 100 days doesn't pay for a lot. Then you throw in other restrictions. First, you have to be hospitalized for at least 3 days without counting the day of discharge. Then you, for example, you break a hip, then you need a few weeks of rehabilitation. In situations like that, Medicare will pay for it. But if you just need help with custodial care or your basic activities of daily living, bathing, continence, dressing, eating, transferring, toileting, everyday activities, if you just need help with that, also known as custodial care, Medicare will not pay for it. If you need 7 days a week, 24 hours a day, Medicare will not pay for it. If you need help because of a cognitive impairment, Medicare will not pay for it. So people find a real nasty surprise. My friend called me up and she says, can you believe Medicare is going to stop payments and the nursing home wants $10,000 a month upfront every month? I was like, well, surprise, surprise. Sometimes we choose not to think about these things. We're not prepared for it. And unfortunately, then things don't turn as good as they could have turned out if we can do a little bit of planning and consider all our options. And that's the purpose of tonight's presentation, is to try to clarify as many issues as possible and to also explain the great value that the Connecticut Partnership for Long-Term Care brings for us Connecticut residents that no other insurance coverage out there can bring, like the Connecticut Partnership for Long-Term Care. Now, why is the state even talking about long-term care insurance? The reality is that long-term care can happen at any age, and the older we get, the greater the chance of possibly needing long-term care. So the risk doesn't go away even if we just ignore these issues. In the Northeast, Connecticut, many states, cost of care is very high. If you move to Texas, Mississippi, Alabama, Louisiana, New Mexico, South Carolina, many states out there, the cost of care is not as high as the Northeast. So where in Connecticut, it's $456 on average. You can find places in different parts of the country where the cost may be $300 a day, $350, $280. So where the cost of living is high, the cost of care is also high. Medicare, health insurance, the Affordable Care Act don't pay for long-term care. And with Medicaid, none of us wish to get rid of all our assets so that we can qualify for Medicaid. Obviously, we want to avoid needing Medicaid as much as possible if we can avoid it. And another reason why in Connecticut we talk about long-term care is because of this special program, the Connecticut Partnership for Long-Term Care. The state of Connecticut was very innovative and proactive back in 1990. Governor Bill O'Neill at that time, he created a task force to study the long-term care issues, the long-term care marketplace options that were available. And after a good amount of research, there were conclusions that even if you buy a long-term care policy, if you don't buy enough, you may still run out of insurance, still need care, and become impoverished. So the partnership answered the question, how can we make this better for Connecticut residents? How can we give people more peace of mind and guarantee a higher amount of assets to be protected, even if they run out of the Connecticut Partnership insurance policy for those people that have it? And today, we're very glad to see that there are 45 states throughout the country that have partnership programs. And instead of me trying to tell you which ones the 45 are, let's start off with the 5 that don't offer it. Hawaii and Alaska don't have partnership programs. Mississippi, Massachusetts, and Vermont don't have partnership programs. They both have talked about it. We've even had meetings with Massachusetts. At one point, we thought they were getting ready, but that has not happened yet, and we don't know if at some point they will. It all comes down to what happens in the country with legislation, what incentives there may be in the future to try to tackle this problem and give people more options of making long-term care insurance even more affordable to the general public. So the partnership was created with 4 goals. The first, to help us Connecticut residents have a better way to plan for long-term care and protect our assets should we need long-term care. And here's the key, without the risk or fear of becoming impoverished. I will tell you all about how that works, that only the partnership can offer such an option. If the state was going to enter into a partnership with insurance companies, then we wanted to make sure that higher standards would have to be met. So non-partnership policies do not have to meet the higher standards that partnership policies require. And there is a long list of differences, but one example is that partnership policies from day one required automatic inflation protection compounded to be built in with policies so that the policies would grow and hopefully keep up with true inflation. And incidentally, 95% of partnership policy holders who have filed claims did not exceed their long-term care policies. And for the 5% that ran out of insurance, then they had the added safety net that only partnership policies have. And that 5% is going to get bigger and bigger in time, because as we're getting older, more people will be filing claims, and with 10,000 baby boomers a day until 2030, long-term care services will be in very high demand. And again, hopefully more solutions are found to help the majority of the population. To try to educate the public as much as possible, each year I do a presentation with the UConn Law School. I work with human resources organizations, the Connecticut municipalities organization. So any group that would like for us to talk about the partnership and long-term care issues, we'll be more than happy to meet with them, as we're doing here tonight. And the last year, the last goal is to conserve state Medicaid funds. Since 1992, there's a formula in place that shows that over $64.9 million have been saved by the Connecticut Medicaid program, thanks to the partnership. Because, as I briefly mentioned before, as more and more people have purchased partnership policies, then you have less people, and even people that buy long-term care non-partnership policies, then you have less people relying on paying for care through their income assets, and unfortunately, eventually run out and have to rely on Medicaid. So more people buy insurance, less people have to rely on Medicaid. Now, excuse me, here's where the partnership is separated from non-partnership policies. Basically, we buy a policy from an insurance agent, just like we buy homeowners insurance, automobile, disability. So we're buying insurance with the agent, and we have a contract that is issued between the person that buys, the policyholder, and the insurance company. So from that perspective, it's no different than any other insurance policies. Basically, you pay premium, you hope and pray that you will never need long-term care, but if someday you do, you file a claim with the insurance company. And since 1992, $930 million have been paid through claims through the partnership. Now, when we buy a long-term care partnership policy, we're buying insurance, again, an insurance contract with different features. The features are a daily benefit amount with a cap. You can buy also either weekly cap or monthly cap. And you also buy what's called a lifetime maximum. It could be to last 2, 3 years, 5 years. In addition to the insurance features, then we have a special account called Medicaid asset protection. And that's only through state law, available with partnership policies only. And the Medicaid asset protection account starts out at a value of 0, regardless of how much insurance you have. The account is activated the moment that you file a claim and the insurance company approves paying benefits, and they begin to pay benefits. $1 of insurance paid gives you $1 of Medicaid asset protection. It's a simple formula, dollar for dollar. If in a month, $10,000 is paid through your long-term care partnership policy, then you have $10,000 of Medicaid asset protection. 5 months, $50,000, you have $50,000 of Medicaid asset protection. So the more the policy pays, you have an equal amount of Medicaid asset protection. Now, the Medicaid asset protection is not a bank account. It's not something where you can pull money or add money. It is a value under your name. And this is how it works. Let's say that you have 2 Connecticut residents, exactly same age, same sex, same everything, same health. Let's say they are both 67 years old, 2 females. One is a $300,000 non-partnership policy, and the other lady is a $300,000 partnership policy. 10 years later, unfortunately, they both need long-term care, and they file a claim with their respective insurance companies. The lady with non-partnership has $300,000. In about 2.5 years, that's all spent, and now she has no more insurance, and she still needs care. So she applies to Medicaid. Medicaid says, you're single, you have to spend down your assets to $1,500. So I'm getting a senior moment here. I need long-term care. $1,600. The second individual who has a partnership policy that has a $300,000 pool of money. Unfortunately, she needs care. She files a claim. She's approved, and the policy begins to pay benefits for her, and that's the partnership policy. Remember, $10,000 paid gives her $10,000 of Medicaid asset protection. After her policy pays $300,000 of Medicaid asset protection, that's how much she has in her account, because whatever the policy pays, that's how much you have as Medicaid asset protection. Now, when she applies to Medicaid, Medicaid says, you're single. Normally, you have to spend down your assets to $1,600 before you qualify for Medicaid. But she gets to keep $1,600 plus $300,000 to do as she wishes. $300,000 is protected assets if she has them. And nobody will say you have to do this or that with $300,000. Those are protected assets recognized by state law. And this single person at that point, she can either keep it, give it all away, give it away a little bit at a time. She can spend it. Again, it's her choice. Here's something interesting about Medicaid asset protection. As you know, there's a 5-year look back period with Medicaid. Whether that stays at 5 years, time will tell. Because Medicaid has some serious challenges, and some people think eventually the look back period may end up being a longer period. But let's stay with 5 years right now, what we have in front of us. If your partnership policy is paid $200,000 and you still have $100,000 left in insurance, if you wanted to, you do not have to wait until you run out of insurance to transfer your assets. As long as your partnership policy has paid a certain amount, you can transfer assets, and as long as they're less than what the Medicaid asset protection you have earned, then you will not have any problems with Medicaid down the road when you apply to Medicaid and they check the look back period, which is 5 years. But we'll talk a little bit more about that. What I want to say here before we go into some examples, when determining eligibility, the Department of Social Services, where Medicaid claims are processed, as it states right here, will disregard any assets you have up to the amount the partnership policy is paid in benefits. To demonstrate how Medicaid asset protection works, here are 4 examples. And we have Alice, which is based on a real situation. Bob, Cindy, and Dave. Took us a week to come up with the names, but we finally had agreement. Everybody's got opinions. Kidding aside, assets, how much each person has here. And then you have the third column, partnership policy benefit payments. This is how much the policy paid or not, as in David's example. And then you have countable assets. That's how Medicaid will review each situation and what their conclusion is, the number of assets that may have to be spent down or not. Alice did not want to do anything creative. There are ways that you can set up a trust, or you can hide your assets, or different things that are illegal that people choose to do. If you transfer all your assets to somebody else, there are risks. If they get divorced, or if they spend the assets, if you no longer have control over those assets. So obviously that's a very important and careful decision that needs to be made. And it's important to consult with professionals to get the proper and correct legal advice. But Alice here had $100,000 in assets. She chose to purchase a partnership policy with a pool of money of $100,000. She heard about it. She liked the concept, met with an insurance agent who was certified to sell partnership policies because they go through special training to get certified. And if they're not certified, they cannot talk or sell partnership policies. Unfortunately for Alice, 2 years later, she developed Alzheimer's. At that point, she filed a claim with the insurance company, which began to pay benefits. $50,000 paid, she has $50,000 on Medicaid asset protection, $100,000 paid, she has $100,000 on Medicaid asset protection. She runs out of insurance, she files a claim with Medicaid because she has no more insurance. Medicaid says, Alice, you're a single person, you have $100,000, you have to spend it down to $1,600. Alice says, wait a minute, and she shows Medicaid the reports required by state law for insurance company to produce them on a quarterly basis when somebody has a claim approved and benefits are paid. So she has a quarterly Medicaid asset protection, the last one that shows that the policy is paid $100,000. That gives her $100,000 of Medicaid asset protection. So now she can go on Medicaid protecting $100,000. Once it's official that those are protected assets, she transfers $100,000 to her daughter to help pay for the grandchildren's education and other expenses. And then she went on for 4.5 more years on Medicaid until she passed away. So here we have an example of a person that in some circles maybe may not have very high assets, but she purchased a partnership policy that paid out $100,000. And her policy first took care of her in the first 1.5 years or so. And then Medicaid paid for the rest. So she achieved the equivalent of unlimited coverage because her assets were first protected when the insurance policy was paying, and then her assets were protected a second time when Medicaid kicked in, recognizing that her policy had paid $100,000, given her Medicaid asset protection worth $100,000. So as you can see here, under countable assets, she has 0 countable assets. Now, Bob here is the same example, except he worked 2 jobs and he managed to have $200,000 in assets, buys a partnership policy that pays $200,000. 7 years later, files a claim with the insurance company. $200,000 is paid out. Again, $200,000 paid. That gives him $200,000 of Medicaid asset protection. Applies to Medicaid. Medicaid says, Bob, you have $200,000 of Medicaid asset protection. You have $200,000 in assets. You have 0 countable assets. And just worth mentioning again, he can either keep it, give it all away, transfer it to his spouse if he's married. Medicaid will not question what happened to the $200,000 once they're considered protected, and it gives them away. A redetermination each year, a renewal. If Bob has kept $200,000 under his name, which has grown to $220,000, then the extra $20,000 must be spent down because he only gets to protect the original amount of $200,000, how much the policy paid out. Cindy's an example of the equity of the program. She has $1 million in assets, meets with an insurance agent to certify to sell partnership policies, and the agent says, Cindy, if you wish to protect 1 million, first you must buy a policy that pays 1 million, and then if at some point you file a claim and the policy pays 1 million for you, then you have earned the right to protect 1 million. Cindy decides to just buy a smaller policy she's comfortable with the premium, which is a pool of money worth $200,000. 10 years later, unfortunately, she files a claim. The insurance policy pays $200,000. She has $200,000 of Medicaid asset protection. She still needs care, applies to Medicaid. Medicaid says, Cindy, you have $1 million in assets. You have earned the right to protect $200,000. The difference of $800,000 must be spent down to $1,600 before you qualify for Medicaid, Medicaid. Incidentally, to keep it simple, all these examples are for single people, and also I'm not applying inflation protection, otherwise I guess more confusing, probably a lot more for me and for you as well. David here is someone who, like many other people, says, "Hey, whatever happens, happens. Take my chances." Or unfortunately for Dave, he learned about long-term care policies and he met with an insurance agent who was not certified to sell partnership policies, and she sold them a non-partnership policy. He never heard about the partnership, so he didn't know any better. 10 years later, he files a claim. The policy pays $200,000. It's non-partnership. It has zero Medicaid asset protection. So when he applies to Medicaid, Medicaid says, "David, you're single. You have $200,000 in assets. You must spend it down to $1,600 before you can qualify for Medicaid." So that's how Medicaid asset protection works. And if there are questions later, we'll answer those questions. You can also send questions through the chat function, and we'll get to the questions soon. One thing that is important is that Medicaid asset protection is free. What that means is that the state is doing it for us. We're taking steps to protect ourselves against long-term care expenses. We're buying insurance. So the insurance company has nothing to do with Medicaid asset protection, except for some administrative steps. But if you get a quote from an insurance company that sells both partnership and non-partnership policies, if the benefits are exactly the same, if you're comparing apples to apples, the premium is 100% identical. The only time the premium would be different is if you're comparing, for example, a policy with 5% compounded automatic inflation protection versus one that has simple inflation protection or 3% or less. So it's an inferior policy because over time, the 5% compounded will grow much faster and to greater amounts. One extra value here, the state of Connecticut is required through Medicaid to recover funds paid for an individual's long-term care nursing home when on Medicaid when the person dies. However, if those assets were protected through the partnership, then the state will not try to recover those funds for Medicaid. One question obviously that comes up, hey, I'm going to be moving south or north or somewhere. I like warmer climates, or I like skiing. I'll be in Vermont or Maine or New Hampshire. So what happens when you buy a Connecticut partnership policy and then you move? Well, after you move, you have a new address and probably a lot of other things. But remember that you have a contract with the insurance company, so you're taking it with you no matter where you go. Anywhere in the country, if you need long-term care, you file a claim with the insurance company, and then the process goes through file, approve, need more information, the NIA claim if the person doesn't qualify. About 95% of people who have filed claims with the partnership have been approved incidentally. So it's good to see that the policies have been working. As I mentioned before, more than $590 million in claims have been paid. All right, so somebody moves throughout the country, they take the insurance policy with them, and it's a contract again. So someday you qualify for claims, insurance benefits are paid, you earn Medicaid asset protection no matter where you are. And some insurance companies also consider Canada as part of the covered territory. If that's important to you, ask an insurance company if they include Canada, because then if you move to Canada and you slip near Niagara Falls and something bad happens or what, so then you'll have insurance over there as well. Therefore, it does not matter much when you first move somewhere else. In order to buy a partnership policy, you have to provide a bona fide Connecticut address, not a work address or a PO box, since we don't know anybody who successfully lives in a PO box yet. So you provide a bona fide Connecticut address. That's just for the application. If 3 weeks later you move, nobody's keeping track of what the individual is doing. So your address, being a Connecticut address, is important when you first apply. And then your address where you live in the future, if you're outside of Connecticut, there's another time when your address is also very important. I mentioned that there are 45 states with partnership programs. Out of these 45, one state from the beginning decided not to have what's called reciprocity with other states, because they think that we all like wildfires, mudslides, earthquakes, and we're all going to move to California, which is obviously totally unrealistic. Unfortunately, California has decided that they don't want to have reciprocity, and they're hurting their state residents, because if I am a California resident, I lived there 20 years, now I'm older, I want to move to Nevada or South Carolina or Florida where my daughter is. If someday I file a claim through the California partnership policy and I run out of insurance, to take advantage of my Medicaid asset protection, I have to move back to California, which, many people really may not want to do that, because if your life is in another state somewhere else, you don't want to be forced to have to move back to California. So outside of California, we have 44 states that have reciprocity with each other. Connecticut from day one was very strongly in favor of it. And I want to point out that since January 1st, 2009, when the 44 states had reciprocity with each other, no state has opted out of the reciprocity compact. Obviously, we don't know what the future brings, but no state has opted out. And there's a realization there that some people move in, move out, people move. So hopefully in the end it's a wash, but the states recognized, in order to make it easier for people to buy partnership policies, they chose to be part of the reciprocity agreement and stay with it. I want to point out here that the reciprocity agreement is not a contract for life. States can opt out of the compact by giving the federal government 60 days notice. So some states may say, well, for this reason or that reason, I want to opt out of the reciprocity agreement. They can also create their own with other states if they wish to do so. But no state has done that to this point. How does reciprocity works? You purchased a partnership policy in Connecticut and then you move to Arizona. Unfortunately, 10 years from now, you file a claim, insurance benefits are paid, you qualify, you're earning Medicaid asset protection. Then you run out of your insurance policy, which pays out $250,000. You have $250,000 of Medicaid asset protection. At that point, you still need care and you apply to Arizona's Medicaid program. As long as at that time, Arizona and Connecticut have reciprocity with each other, then the Arizona Medicaid program will recognize the Medicaid asset protection you earned, and you'll be able to go on Medicaid protecting a larger amount of assets than you otherwise would. If I am in the Arizona Medicaid system and 6 months later, Arizona decides not to have reciprocity with Connecticut, I will be grandfathered in because I'm in the Medicaid program at that point already. However, if I am in Arizona and I have not qualified for Medicaid yet, and Connecticut and Arizona, for some reason, they decide to opt out of the reciprocity agreement, then my choices in Arizona would be to either stay there and pay for extra care out of my pocket, or to move to any state that is reciprocity with Connecticut, my choice, or to return to Connecticut and take advantage of Medicaid asset protection in the original state where I bought the policy. So it's important to remember these things about reciprocity. The state where you live in is not as important today, but it will be a lot more important if at some point you run out of insurance benefits and you're in another state and you would like to take advantage of Medicaid asset protection. Now, keep in mind here that since 1992, we have had 25 insurance companies selling partnership policies. We started out with 3, Travelers, Amex, and Blue Cross Blue Shield, which was quite an achievement at the time because the bar was set much higher and we didn't know how insurance companies would react. So you've had 3, 5, 6, 8. Obviously, insurance companies have different strategies on what they want to do with their business. And today we have 3 insurance companies that sell partnership policies: Bankers Life, Genworth, Transamerica. Now, there are insurance companies that are not listed here out of the 25. They don't sell new policies, but they are 100% responsible to service, administer, and pay claims for their book of business. And the insurance department monitors that as well. One thing I want to point out here is that, as I mentioned before, insurance companies come and go. We don't know what the near future or distant future will bring. But out of these 3 insurance companies, you may want to make a note that Transamerica has announced that as of July 1st, they're moving in a different direction and they are no longer selling long-term care policies. It is our strong recommendation, if somebody is interested in talking and getting quotes from different insurance companies, to get one from Transamerica as well, because until July 1st, you can still purchase policies. And even if they no longer sell them after July 1st, you are still 100% insured with this company. And if you like their numbers and what features they have to offer, it's in your advantage to take some action sooner rather than later, because after July 1st, you will not be able to get a quote. Now, whether things change again in the future, who knows, but time will tell. Bankers Life, Genworth, Transamerica. If your insurance company is not listed here that you bought a partnership policy from, it does not mean that there's trouble. It just means that they're not selling new policies. And the insurance department monitors the financial stability of insurance companies. And just to let you know, as a side note, insurance agents can't really tell you this. They can't say, oh, one insurance company may have financial issues. You don't have to worry about it, because in Connecticut we have, and in other states as well, the Guarantee Health Fund. If an insurance company goes belly up, then we are insured up to $500,000 per individual. If my policy pays $200,000, then it will only pay $200,000. If it pays $500,000, then I have the Guarantee Health Fund up to $500,000. If my policy pays $700,000, as long as things stay as they are, then it would only pay up to $500,000, no more than that. If you have a friend who, or relative, family member who couldn't attend or participate in the presentation, there are a couple of different ways for you to see the presentation. One is by going to our website, ctpartnership.org, and there are 2 videos there. One is similar to tonight, the other one is frequently asked questions that I present both, and they might give you other ideas that maybe you didn't see tonight. You can also go on our website and download many publications under consumer link, frequently asked questions, what to look for in long-term care policies, and the partnership, why the partnership. So there's a wealth of information on our website. Also, once we finish here, I'm working with a lot of different organizations. I'm not sure if this presentation is being recorded tonight, but Susie will tell us about it later. But again, you also, as I mentioned, you have the partnership website to see the presentation again for yourself or someone else. All right, so this is the 800-547-3443 number to request information. If you have questions, If you have a pen, write down another number, 860-418-6318. I'll repeat it, 860-418-6318. That's the General Partnership helpline. If you call there, somebody will help you. Leave a voicemail. These days there are people in and out because of working from home, working from the office, but definitely somebody will be very helpful and address your questions or any concerns or issues that you may want to discuss with us. So at this point, I would like to check to see if we have received any questions. Susie, do you want to open it up as well for any other question?
Yep, we have. It says, what kinds of care are considered long-term care?
What kind of care is considered long-term care? Well, let's say that when I fell off the bike and I injured myself, that I needed help with getting dressed and also with bathing. So normally insurance benefits are paid when somebody needs assistance, physical assistance, with 2 of 6 activities of daily living: bathing, continence, dressing, eating, toileting, and transferring. And those are pretty standard through the industry. Sometimes there are some variations. That's one way to need long-term care. Another way to need long-term care is, take my mother. You know, one day I'm driving around Rocky Hill, that's where she lived, with my sister, and she's outside, it's like 15 degrees out, and she's like this, she has no coat. You know, luckily for me and her, for some reason, I drove by that way in that particular moment. And I said, Mom, what are you doing? And she says, I locked myself out of the house. Okay, we put a key under the rock for this particular situation. And she said, I forgot. Okay, the point is, obviously in time, unfortunately, she was developing problems mentally. And at one point when she left 5 pots and pans on the stove burning, the decision was made that she could no longer stay at home alone. And so we started out with an adult daycare, and then somebody come into the house. So bottom line is, if somebody needs physical assistance for the activities of daily living, that's when they need long-term care, also known as custodial care. Help with everyday activities. The second way is when somebody needs guidance or supervision because of a cognitive impairment. I hope that answers the question. If anything else, please let us know.
Okay, we also have, who determines, approves how much long-term care, ergo number of hours per week, a person needs when they are drawing on their partnership policy?
Okay. The first thing that happens is you speak with your doctor or nurse. They are required to write a letter. This is like the key. This begins the process. And they're going to say, in my professional opinion, I believe that Mrs. Jones needs long-term care, and I expect it to be for the next 90 days or longer. Now, it does not matter if Mrs. Jones needs care for just 30 days or 60 days. What matters is the doctor is putting in writing that his opinion or her opinion, or the nurse, is that they need help with long-term care. Then you call the insurance company and you file a claim and you provide all the information that is necessary. If you're getting care at home, the insurance company sets an appointment with you and the family, as applicable, to send someone from an access agency who is national in scope. There are 6 of them. And these are nurses or social workers. And the primary purpose for them is to come to your home and to write down a customized plan of care based on what they feel is best, the care that you need to stay at home comfortably and safely. It's not something that you have to follow. They're just stating these are the resources that the individual and the family can provide. This is, in the nurses or social workers' opinion, the services that will be needed. So the key is the doctor writes the note, and then the individual needs help with 2 or more out of 6 activities of daily living. And you have a daily benefit amount as a cap. That's the most that the insurance company will pay. So if you need somebody to come in the house 8 hours a day, 10 hours a day to stay safely, then that's the claim that you file. If it's approved, you're incurring expenses, you submit the expenses to the insurance company, or the caregiver, the provider, can submit insurance claims bills to the insurance company directly if you approve it. And so that's how the claim system works.
Okay.
Decision, and it's based on your needs.
All right, Aldo, we have another one. Are you limited to certain nursing homes / long-term care facilities if you have partnership insurance?
Okay, so keep in mind that 95% of Connecticut nursing homes survive based on having Medicaid patients. So the majority of nursing homes accept Medicaid patients. Now, there may be some organizations that might be religious in nature or continuing care community, and those are that's a very limited number. So 95% accept Medicaid patients. And one thing to remember is when somebody's on Medicaid, you're only allowed to have a semi-private room. It doesn't matter if you can pay the extra money, you're not going to get a private room unless you are a risk to yourself or others. So when you go to the nursing home, just start swinging the cane around or make it look dangerous so you get your private room. So I'm kidding. But the majority of nursing homes do accept Medicaid patients. One of the big questions and a challenge for Medicaid when they conduct a financial review of the individual, they want to make sure that Medicaid identifies assets and income. So you have 2 columns. Medicaid is very complicated, but to keep it simple, if you have access to something that you can liquidate it, that will be listed under your assets column. And those assets include a 401k plan, whether it's yours or your spouse's. With Medicaid, it does not matter whose name assets are under. They're considered jointly held. If you have a life insurance policy with cash value and the face value of the policy is at least $1,500, if he has a cash value, then you have to, that will be added to the assets column. So that can be liquidated, and if required, that you will be asked to do so. If you have a pension that can be cashed out as a lump sum amount, Medicaid will list that under assets, stocks, savings. It does not matter if you pay penalties, if you lose money, if you have to pay taxes. Anything that you can cash out will be listed under assets. Now, under income, what you have is Social Security, because you cannot cash that out as a lump sum. And if you have a pension that only pays on a monthly basis, that's also considered income, and that will be with the income column with Social Security. So how does that work? Let's go first to the simpler example, single person. So the single person Medicaid looks at the assets that you can liquidate, and Medicaid will say, in order for you to qualify, you have to spend down your assets to $1,600. So that's the assets column. Then under income, let's say, I don't know, you have $1,500 of income a month, because you're asking Medicaid to pay a lot of money for your nursing home. Medicaid is going to look to you and the family to make some contributions. And so out of all the income that you have, you will be allowed as a single person to keep $60 a month, or 60 plus 90 if you're a wartime veteran. Now, if you want to take this example to a married couple, again, the rules are going to be the same in the sense that Medicaid will look to see what's the category of assets and what's the category of income. Now, normally, Medicaid does not touch the spouse's income. However, if the spouse living at home has substantial income, then there's a formula in place where he or she may be required to transfer some of that income towards the care that the other spouse needs. The opposite is also true. If you're a spouse living at home and you need, I don't know, $5,000 a month to live comfortably for your expenses, and if you only have 1,000 and not 5,000 once the other spouse is in nursing home, then the income can be diverted to go towards the community spouse so that he or she can continue a decent level of living based on what they're accustomed to. I hope that answers your question, but if there's more, please do ask. I would say if you think of something else, or you'd rather discuss in a telephone call, please do call the number I gave before, 860-418-6318. You'll get a quicker answer than if you call the 800 number, because the 800 is in the Department of Social Services, and they may not get to it as quickly because they're working from home, and we have representatives working from the office as well as from home. So we'll try to get back to you as quickly as we can. Very important point that people need to be aware, and that is, there's a lot that we can say about it. Let me just try to hit on the most important points. I understand what you said about somebody is a greater amount of assets. They don't have a partnership policy. They have long-term care, non-partnership. Obviously, you can purchase a great policy as long as you've done your homework and you have a pretty good agent who's made good recommendations based on the assets that you wish to protect. You can achieve it with a non-partnership policy or a partnership policy, except that obviously the partnership policy is more value that non-partnership policies cannot offer. Just to clarify, over the last, about 10 years ago, you never heard of a rate increase. But over the last 7, 8 years, all of a sudden, it does not matter if it's partnership or non-partnership. Policyholders have seen rate increases, and in some instances, significant rate increases. 1992, in 1992, 1990, insurance companies did not have any experience with long-term care. They put it together based on concepts from life insurance, health insurance, disability insurance, and studies that they had. And 29 years later, hello, surprise, when I was charging you $1,500, maybe I should have charged $2,700. So they missed the boat as far as the pricing. Claims are higher than expected. People are living longer. Return on investment turned out to be less than what they had built with the rates. Lapses were less than what they anticipated. And on top of that, the Connecticut Insurance Department requires for insurance companies to set aside 60 cents out of $1 to pay for present and future claims. If the insurance company proves to the insurance department that they're saving 45 cents instead of 60. Then the insurance department has no choice but to approve the rate increase. Now, I am very encouraged. There's a lot of attention on this topic because it's a great concern, as I could hear from your voice as well. And I'm on the same board right now myself. You know, I just looked at today, I had a 45% rate increase. It's encouraging to see the National Association of Insurance Commissioners. They're coming together, hopefully this year, to try to come up with a uniform approach regarding how to handle rate increases. Some people say, hey, look, if the insurance company made more money, they wouldn't give me anything back. And if they made mistakes 20 some years ago, then they got to look in some other parts of their profits and find ways to build up the reserves. Obviously, not everybody shares the same opinion. And I've seen, now I don't want to promise anything here. I'm just telling you, it's a little bit encouraging. There are a number of bills in Connecticut that are being considered. And the more noises you can make with state legislators, the better, because this is how it has all come about. And there have been new regulations thanks to people calling and registering a complaint about their long-term care premium being increased. So there are some bills that are looking at different options. Do we limit rate increases at a certain level, for example, 75%, and you will never get a rate increase? I do not know if this is going to happen. I'm encouraged to see that these are a part of the discussions. And there's been a lot of pressure, people calling state legislators, explaining what's going on. I've been insured for 20 years. I never filed a claim. And now because there are problems with the pricing that I have to pay higher premium. One thing I tell people, and I get a lot of phone calls, and I try to help people understand what's in front of them and explain that we're in a situation where we have to try to manage what we can do. And so we go over different options. For example, somebody may have $500,000 of insurance, or even 800,000, 700,000. They've been paying premium for a long, long time. How much premium have you paid? Well, I paid 40,000 so far, 30,000. And you have a pool of money of 300, 400, $500,000. Do you really need all this insurance? Do you need 5% compounded automatic inflation protection? Or perhaps you could make a switch to another inflation option that the insurance company offers, which will save you substantially. Maybe you can switch from monthly payments to annual payments where it applies. You can save some money that way. If you have a 0 days, elimination period, or 20 days or 30 days, are you okay with having maybe 90 days elimination period? That will save you some money. If you have extra riders, maybe eliminate some. Anyway, those are the discussions that we have. It doesn't make it much easier in some instances. In some instances, it's very helpful. Two of the regulations that came in place 5 years ago include, if there's a rate increase approved of 20% or higher, then the insurance company must roll it out over a period of 3 years. It's not the greatest, but it's something, so you're not hit with 30% all at once, or 20%, or whatever the amount is. So it's spread over 3 years. Also, when somebody has experienced a 50% or greater cumulative rate increase from day one, now they have the option of choosing any insurance feature that the insurance company offers with their policies. And even if it's below the minimum partnership requirements, then they still maintain a partnership policy, where before they would lose their partnership status. One example is that has worked. Some people, 78 years old, he says to me, I don't need as much growth anymore. I have 5%. I'm going to reduce it to 1% automatic inflation compounded. And I have $500,000 pool of money. My daily benefit is like $500. So I don't need as much growth. The cost of care is 456. So he was able to reduce the cost of insurance by, unfortunately, reducing some of the insurance benefits. But that's the reality we have right now. We're hoping that within the next year or so, things change, and we hope better laws are in place to protect the consumer further. Yeah, so I've seen many different situations. Sometimes somebody's reducing the pool of money from 400,000 to 300,000. I mean, again, this is not ideal for the consumer. I think the insurance department, they say their number one goal is to protect the Connecticut consumer. And their big concern is that if they stop allowing insurance companies to increase rates, what happens if some insurance companies go belly up? I mentioned to you the Guarantee Health Fund before. That's the safety net. But again, if there are too many companies that have to rely on the Guarantee Fund, these are steps that we have never run into before. So they're trying to compromise and see what's the best formula to maintain both the stability of the insurance company, so they're around to pay claims in the future for future claimants as well. But I hear you, it's tough. We're hoping that better things are ahead through legislation.
Aldo, thank you so much for your informative talk today.
Oh, you're very welcome. Thank you, everyone, for staying with us and for tuning in. If we can help in any other way, please do contact. And thanks so much to Susie and the library for hosting the event.
Have a good night, and this will be recorded. Thank you
All right,
again.
great. Thank you. You take care.
Bye-bye.
Bye-bye.